Hey y'all, it's me, Dr. Smearman, Gyno Girl. I'm really excited today. I have a good friend colleague here, Dr. Shieva Ghofrany. She is a wonderful, wonderful advocate for patients and a board-certified OBGYN who's going to talk to us about her journeys and her advocacy work that she does. I will give you a brief synopsis of all the great things she does. She strives to help women eliminate their fear of being proactive, not paranoid about their health. And she's an OBGYN since 1999 and co-creator of the tribe called V. Her intention is to increase our knowledge to decrease our anxiety, which is very similar to what we do here, which is, we educate so that you could advocate. So we're on the same page here. And she's travailed 6 miscarriages, 3 births, endometriosis, weight loss surgery, and ovarian cancer. And she's harnessed her personal experience coupled with professional observations to generally help achieve a calmer perspective. She loves engaging with women on every level to guide them realistically in the quest for understanding of their bodies and minds. She is very active on social media. She has a big presence. She has her website and a group called the Tribe Called V, and I'm going to have everything in the show notes for you to discuss. But I just want to jump right in it and talk to Shieva, Dr. Shieva Ghofrany. Welcome.
Hi, welcome.
Presents Sex, Drugs, and Hormones. So
I love it. I love it. I don't know if I should be like more excited about the sex or the drugs or the hormones or the intersection of all, right?
Yes. I started this podcast, in order to get the more information and education out there on these topics. And in my first episode, I talk about my own journey with vaginismus because I think that people really can learn a lot, not only from what the data is and the patients that you've treated, but actually from people's journeys, right? Like that's like a big part of that can really capture and mesmerize, I think, patients to kind of think twice about like themselves and maybe even learn from how they advocated for themselves. So I had Dr. Corinne Men, who we talked about menopause and hormones, and she talked about her breast cancer journey, as well as this week, April Patterson, who's a good physical therapist friend of mine, she's pelvic floor PT, who's a PGAD expert in persistent genital arousal disorder, talks about her journey and how she overcame that. So I love the fact that, I hate the fact that we have to go through these things, but I think that that we can harness that and then, try to help others learn the best way to advocate for themselves and their own health is what the key take home is. So I love that you do that. And I'm so happy to have you here. I want to start out with just, you've been through a lot. I think that there's been a lot that's been going on for you between, trying to have kids and endometriosis, which we all know can be a difficult diagnosis, a difficult treatment, a difficult management. But to then find out that you have ovarian cancer, tell us about how that started. Like why did you have the surgery? And because I've obviously heard you speak about this, but tell us your journey into finding out, how you had ovarian cancer. And then really I want to talk about how that diagnosis, because I know you talk about how we give diagnoses and how we give these treatment plans are so critical to how patients can absorb it and then process it as a cancer survivor. So let's do it. Let's talk about it.
Well, first of all, thank you. Thank you for all of it. And I think you agree, right? That us being able to talk openly is so valuable, not only because I feel more healed every time I talk about my own journey, but I think there's no doubt that you and I can have more empathy for our patients and not to sound transactional, but more buy-in, right? I think that if patients know that we've been through, and it doesn't mean we have to have experienced every single thing that a patient has gone through, but if they know we've had somewhat of our own health journey, they recognize that we get it and that we're not just this distant doctor-patient, which is what it kind of used to be like. And so I think that is the most valuable part. And like I said, it's very healing for me to be able to talk openly to our patients and have them believe me. I always joke that I have a lot of street cred with my patients because if I say you need a pelvic ultrasound, they're like, I'm going to get a pelvic ultrasound because Ghofrany found her cancer. Right. So in a nutshell, if I can nutshell this, which is as you and I know, our health journeys are hard to nutshell, but yes. I had, like many, many women, anyone out there listening knows that the journey through endometriosis is long and challenging. The average length we know is anywhere from 5 to 10 years before you're diagnosed. I was the daughter of two very educated doctors. We're a very close family. And despite that, because I was born in 1970, where really the understanding of endometriosis was far less than it is even is now, and it's still not great.
Right.
It took until I had a 17 centimeter endometrioma in medical school. And I had a profound pain. That was when we discovered my endometriosis, despite the fact that I had had years of strange abdominal pain, persistent, period pain, almost passing out, all these things. And was told by, my family in a loving way, like, oh, it's just your period. Yeah. So the 17 centimeter endometrioma was my first discovery of, okay, you actually have endometriosis. I had it operated on. I was a resident. I was a medical student.
It was were you having pain?
No, I was actually having pain with intercourse in medical school with my now husband, and was diagnosed and was abroad in Tel Aviv in medical school, and called my mother saying, hey, I'm going to stay here to have surgery. My mom said, no, you'll be coming home where we know all the surgeons. So I came home, I had the surgery. I salvaged the small amount of my ovary. And the rest of my pelvis was luckily clean. But from a stage perspective, my endometriosis stage was stage 4, because the endometrioma, for those of you listening who don't know, which means a collection of endometriosis in my ovary, was so big. That's relevant to the ovarian cancer story, because flash forward years later at age 45, my pain had really subsided. From age 27 through 45. I didn't have any pelvic pain or evidence of endometriosis while I was going through 6 miscarriages and 3 pregnancies. Because as we know, that consistent anovulation coupled with a little bit of birth control in between just kind of stopped my period from being painful. Right. Until 45-ish, perimenopause-ish, had my tubes cut. So I was off birth control, and my pain started increasing just during my period. Yeah. And I told myself as the doctor, it's probably endometriosis coming back. Yeah. And a couple months into it, when I would be lying in a fetal position.
No, I'm just saying there's no cure. I just wanted to say we don't have a cure for endometriosis.
We don't have a cure. We have multiple more aggressive ways of treating it now, medically and surgically, but still no cure. Because we still don't even know really what causes it, right?
Yeah, exactly.
So the pain started getting worse and worse, to the point where in between work and surgeries and delivering babies, I would be like in a fetal position. And again, for everyone out there, if you're lying in a fetal position, that is too much pain, please go to your doctor and tell them you need a pelvic ultrasound. Do not allow them to say, I did a pelvic exam or anything other than I need imaging of my pelvis.
Right.
Which will not always diagnose endometriosis, but you at least need that.
The MRI, and even that might not
diagnose it. It's a diagnosis that is often done clinically. Yeah. So the ultrasound showed a 4 centimeter complex cyst that my ultrasound tech in my office very clearly said to me, you and I know it's probably endometriosis, but you and I know that you would send a patient for an MRI. Right. So you need to do it. And I said, okay, I will do it so that I can be valid with my patients and say, I did it too. Thinking for sure it's an endometrioma. Yeah. And as it turns out, the radiologist called and said, this endometrioma looks irregular.
Oh, interesting.
I said to him, I think you're overcalling it, but I'm in so much pain, I'm going to get it operated on anyway. Don't worry. And within a week, I was in my gynecology oncologist office, who had taken care of me and trained me during residency, which is why I picked a GYN oncologist. The truth was, I really thought it was benign, as did she, because it's rare that endometriosis becomes ovarian cancer. Right. But lo and behold, mine was one of those rare cases where the endometrioma had malignantly transformed into stage 2 ovarian cancer. And during my staging procedure, unbeknownst to my surgeon, who was an incredible, very adept, very well-trained surgeon, my bladder was also perforated. Oh, wow. So a week after my robotic surgery with staging and everything, I had to go back to the operating room for a vertical incision to fix my bladder, which then led to my incision opened and I had to have a wound vacuum kind of closed. So there was a long journey of healing from my surgeries that, again, taught me so much about being a patient in ways that were different than my previous journey of being a patient. And then I had 6.
It wasn't just the ovarian cancer. There's also issues with the bladder and how it heals. And I had to have a full catheter.
I had to have a catheter for 2 weeks. Yeah. I had to have a wound vac for 6 weeks. But it really, I'll tell you what it helped me the most with, interestingly, is just the nuances with regard to how to talk to patients about their journey. For example, I've always felt very strongly that if you're going to have surgery, you need to have a good surgeon, but you need to feel good about your surgeon. It is not enough, I don't think, for someone to say, oh, Dr. Ghofrany is an amazing surgeon. Don't worry if she has a terrible bedside manner. She's a good surgeon. I actually have never felt that was good enough. I think you need the energy. But after that experience, I felt it even more because I love my surgeon. She's an excellent surgeon. She has a great reputation, which made it easier for me to accept that the complication was not her fault, was not something she did wrong. Had I gone in there thinking, well, she's supposed to be good, but she's not nice, or I don't like her, or it really would have changed my healing and my entire feeling about the situation. So I really impress that upon patients. And I tell them very openly, despite being with a great surgeon, I had complications. So I'm not going to be one to say like, go to this best surgeon, nothing will happen. Things will happen, but they will be rectified.
Exactly. That's the key, is how to treat it. Because I think so many times, historically, at least, patients sometimes go to like gynecologists who maybe don't have as much experience in endometriosis. And then we call it the peek and shriek, where you see a lot of endometriosis. And because you're not trained in or you haven't done enough of the surgery, it becomes one of these things where you have to get reoperated on. So it is very important to either get someone trained in endometriosis surgery who has experience in endometriosis surgery. Maybe they predated the MIGS, fellowship, or like you said, a GYN oncologist who are, pretty much the cream of the crop when it comes to GYN surgeries.
Right. And also, if you walk into that surgeon's office and somehow do not feel energetically good about that surgeon, no matter what their reputation is, I would actually say get a second opinion, because I want every patient to walk into that surgery feeling confident. Right. Emotionally and surgically. Right. So so that was just a tremendously bizarre, interesting, terrible, wonderful experience all in one. I learned so much. I got to experience beautiful love and engagement from people that I wouldn't have expected. I also unfortunately went through a lot of physical pain and anxiety about I have 3 children at the time. And so I had 6 cycles of chemo. And then finished. But the truth is, through it all, I was lucky enough. I mean, I say this very openly that I get called a lot and asked a lot to speak about resilience in the face of cancer. And I'm happy to do it, but I'm also very careful to make it clear that I want to recognize and verbalize my privilege in this, right? I was privileged enough not only to be white and educated, but also to be a doctor who's a gynecologist, who understands it, who has family and friends who could support me, despite everything I've gone through. So I never want my story to be the rah, resilience. You can do it, girl, because I did it too. When people have a lot of other limitations that I just didn't have. I mean, truly, when I think of the levels of privilege, not just that I'm white and educated, right? There could be a white educated pediatrician who wouldn't have had my privilege of being an OBGYN. Right. So I was very lucky. And I also, because I knew enough, I advocated for myself, right? I made sure that I got my MRI right away. I went to the surgeon right away. And the benefit of that now is that I can really convince people of knowing their body, learning about the signs and symptoms of ovarian cancer, recognizing there's no screening, recognizing that finding it really requires a mature relationship between a patient and doctor, where the patient comes forward with symptoms, urges the doctor to do an ultrasound, recognizes that the ultrasound is not the end all be all, but is the best thing we can do, and really pushes if they don't feel okay. Exactly. And doesn't get angry at the doctor when the ultrasound is normal and the insurance doesn't pay for it, and doesn't then get into the oh, next time I'm bloated, I don't want to go see the doctor because last time things were okay. In other words, you and I know that the vast majority of patients with symptoms of ovarian cancer will not have ovarian cancer. But if we don't intervene frequently and have a low threshold to look, we'll miss those patients and we'll have all of the stage 3 and 4 ovarian cancers that we're seeing right now, as opposed to the stage 1 and 2, where the survival rate is so much higher. Yeah.
Right. And I think that's one key take home point, is that when you see your gynae every year for your annual, right, we're screening you for cervical cancer. We're looking at your vulva. We're looking at what's
the breast exam,
the breast exam, all that stuff. So there is some screening being done. But because of the way and the manner of ovarian cancer, we do not have screening tools for ovarian.
Exactly. None. So I'm so glad you said that.
They're very vague. And that's because they're usually advanced stage before people get diagnosed.
Right.
And so you're in this catch-22 in some capacity because you're like, well, we don't, tumor markers aren't, the best thing to screen. They don't screen for ovarian cancer, and ultrasounds don't screen for ovarian cancer, but it's something to start with, at least the ultrasounds for sure.
And to kind of clarify that to everyone listening. So when you go to the gynecologist, just like Dr. Rahman said, you're only really getting screened for breasts by having a breast exam and maybe a mammogram. And you're getting screened for cervical cancer through your pap smear. And if you're 45 or older, you're getting screened for colon cancer and looking at your vulva. But there's zero screening for ovarian cancer, which means you have to come forward with the symptoms being if you have bloating or pain or pressure for more than 2 weeks. I tell patients, do not freak out. You likely don't have ovarian cancer. But if every single person who has those symptoms blows it off, we'll miss like that one out of maybe 1,000, maybe 5,000, but we'll miss them. Because all the studies show, as you and I know, that they wait on average about 6 to 8 months before they come to the doctor, or they go to the doctor and the doctor does that mental math of thinking it's probably not ovarian cancer. It's probably UTI, probably painful periods, probably whatever. And that's why I keep saying very vocally, no. The patients have to come forward and the doctors have to have a low threshold to send for an ultrasound, which is not screening. At that point, it's considered diagnostic.
Right.
Screening, for the audience listening, screening meaning where you have no symptoms, you just come in for a test that we know will pick up things early. And that's not what the ultrasound does for ovarian cancer. And so that whole learning process is something most patients don't know and most doctors don't have the time to do, right? And that's the problem in our system. We as doctors don't have time to teach.
Right, exactly. And so I think, one key point, and this, I don't practice obstetrics anymore, as you know, but when I do have a patient that does get pregnant, especially when they're a woman of color, particularly my African-American patients, they get a little freaked out that they're pregnant now. And I do, I have a private practice, so I'm able to spend a lot of time with my patients. And they're like, Dr. Mom, what am I going to do? The mortality rate of Black women is so high. Like they freak out. They're not, and I always talk to them like, listen to your body and advocate for yourself, and do not stop until someone listens to you.
Yes.
Like I think that's, we're in this profession. We know how to navigate insurances and hospital systems and all that, but the lay audience doesn't. And so that's what I always push with my patients. I'm like, if it doesn't feel right, if the baby's not moving, these kind of things, like you push and push until somebody listens. Right.
Right.
And I
Which
think
is so hard. Yeah.
Right. Because you don't want to, I don't want someone to think that I'm saying they're racist because they're not listening. And I'm like, well, it exists in medicine. And it is the cause of most of the mortality that we deal with.
Right. And you and I think would say that to all of our patients, certainly Black patients, because we know they are absolutely, there is medical racism and we know that they are dying at a higher rate. And outside of death, thank God it's not frequent, but complication rates are higher. And that's true for all patients because there's such a rhetoric in medicine, a little bit of patriarchal medicine, but part of it in defense of us as doctors is that we don't have the time because of the insurance model. And that's why I always say to patients, it's not enough for me to think things are okay. I need to walk you through the process. I say to patients all the time, if you give me a complaint, I will never say, oh, it's nothing, period. I will say it's likely nothing to help calm you down, but let's check it out. Yes. Let's do ABC, but I also say to my patients, what I need from you is a level of maturity where me being able to include you in my process doesn't lead you to say to me, oh my God, now I'm freaking out. Now you're making me scared. Because the minute you do that as the doctor, then I retract and think, oh God, I don't want to scare my patient. So let me just not even blow things up, but just like cut some corners to calm her down or not include her. And so again, I think you and I probably really agree. Like we want to do better and we want the medical community to do better, but we need patients to be mature in how they enter our system so that we can communicate really transparently without feeling like we're scaring people, right? We want to be open and honest and help find things early so that we can prevent later stage disease and things like that.
Absolutely. And I think that, we do have a broken system, which we can't fix. And we are, obviously like deep rooted patriarchy has had us accept, like I think Sue Dominus was, when she was at the It's like we as a culture have an acceptance of women's pain and suffering. And I do like, across every subspecialty, like we could say that, that is the case. But we also like aren't going to take it either as women, right? We're just going to like at least our generation of women are just, that's why all these movements are happening. And I think, I love all the advocacy groups that pop up, the tight-lipped, the menopause advocacy groups. And I think that's why they've popped up, right? Because they recognize that they've either been gaslit by their clinician, or, that the government and such has not supported, their research, or the insurance models aren't supporting their appropriate care.
Yeah.
But we have our system, we know how it works, and we just have to figure out how to push for ourselves. And that's what I think Dr. Ghofrany and I both want you guys, you that are listening, to understand that this is, the onus of healthcare is, of course, on the clinicians and the healthcare system, but it's also on the patient. So we have to really push for ourselves when it is the case that we aren't getting listened to, which is unfortunate when that happens. And we do apologize for all medical professionals.
I know we do. And also, listen, I think that it's also from a place of privilege when I say to patients, if you have found that your doctor doesn't listen to you, please find another doctor, because I recognize that not everyone has a choice in multiple different doctors because of insurance, or because of geography, or just because of life. Like you and I, again, still being privileged, don't have the time to go to 5 different doctors because we have careers and families and things like that.
Right.
But it is so important to feel as if your doctor is listening and explaining why they think you're okay or not okay. If they're not explaining why, it's not necessarily their fault, but you really should find someone who can do that better.
Absolutely. I think that's wonderful. And then let's talk a little bit about, how did you get your diagnosis? Because you said this was an attending that you worked with as a med student,
when I was a resident, she was our GYN oncologist, and so she trained us. Yeah.
So you had a special relationship with her, and obviously, again, we know the profession, we know, the pathology. And so you went in thinking that you had an endometrioma, right?
Yeah, we went in. So both of us went in believing it was an endometrioma for various clinical reasons, but knowing that it could be that the radiologist could very well be correct, that it could be malignant. So I was prepared psychologically, and my consent form was prepared for a possible staging procedure.
Okay.
And it's a much longer story, but in a nutshell, the initial pathology said borderline tumor, which for our audience means a pre-malignant, kind of a almost cancer, but not quite. And a GYN oncologist will always stage a borderline tumor, whereas a general gynecologist might not. So it was actually good that I was with a GYN oncologist. And then the final pathology came back that it was endometrioid, meaning from endometriosis, that was ovarian cancer, which does confer a slightly better prognosis. So I was lucky about that.
Right.
And it also presents more easily because it was very painful.
Right.
Yeah.
So, and then so she told you that, she had, that this was, she told you it was cancer, right? From the get-go.
Well, yeah. Again, long story, but in the recovery room, I woke up and realized this was a bigger surgery than I thought based on how I felt. And she said, oh my gosh, it was a borderline, but we got it all out. I did the full staging. You're going to be okay. And then 5 days later, when I had been readmitted with what we at that point didn't yet know was my bladder being perforated, then the final pathology came back and initially said high grade serous cancer, which is a worse prognosis.
Yeah.
And then it got sent to Dana-Farber where they confirmed. So my poor oncologist, who really was almost a friend mentor, right?
Yeah.
She comes in very upset, but appropriately saying, I can't believe I have to tell you that you have high grade serous stage 2. And this is the most important part though. She said, but you're going to be okay. You're going to go through 6 months, it's going to be 18 weeks of chemo, and you're going to be okay. And that was all I needed to hear. I was like, okay, well, this is going to suck, but I'm going to be okay. Statistically, she said it. I believe her.
Yeah.
That is what I need to know. I'm not going to keep mulling over the alternatives. So it was a fascinating thing. I will tell you the parts that really also taught me so much were, it is no joke that we do not talk about surgical menopause enough with our patients and the effect on our body. We just don't. I mean, even my doctor, my oncologist, my GYN oncologist, my team, as great as they are, it's not their fault.
Right.
They don't have the time. They don't have I don't want to say knowledge, but not even really the knowledge. Thank God that more of us are talking about it now on social media for people to hear about it and learn.
Right. And so I talk a lot about menopause here, but Surgical menopause, of course, you get the ovaries taken out, you're in immediately menopause, right? So did you have immediately all the hot flashes and the night and the sweats?
Immediate. I mean, Samina, I will tell you that I was 46 and I described it as anxiety running through my veins, because it wasn't just like, oh, I'm a little hot. It was like that true inferno from within coming out that made you feel like there was like a shrill in your veins. It was really dramatic. And I was, again, lucky to, I had it for the first several months and managed it through chemo, frankly, with like things like Xanax to help keep me calmer. And for me, giving up sugar is actually a really profound difference in my hot flashes.
Oh, wow.
They were a very big trigger for me. And I managed it through a lot of different means until a year ago when I decided to go on hormones. And now I'm on hormones as well.
Oh, wonderful.
Yeah.
I think that, that is the big shocker. And it's unfortunate. I mean, now you're right. Everyone's talking about menopause because we're having a moment here in the social media circles, at least. But I think that also like we're Gen X, right? We're going through perimenopause and menopause. And it's like this thing where like, we're going to advocate for ourselves and speak up when we weren't told this. And I think this is, again, something I hear at my patients all. Why did not anyone tell me that this was going to happen to my body? And anytime I have a late 30-year-old in my office and I'm an annual, I'm like, we give puberty talks. So I'm going to give you a peri talk. So don't freak out, because then some people are like, why are you talking about perimenopause?
Right. Well, and that getting back to the maturity, patients, I always joke when patients are like, how come no one ever said? And I'm always like, hold the phone, girls, because I have said it. And you guys are the ones who, when I say it, are like, my God, why are you talking? You're freaking me out. So I'm like, you can't have it both ways. You know, those of us who are willing to talk about it.
Yes.
Don't silence us.
And then other patients are like, well, thank you for, even bringing it up. And I'll always preface this. I'm not saying that you are in perimenopause, but I want you to know this is what may happen. Yeah. Sometimes it happens in your late 30s. So this is why I bring it up to you. And I tell them, we give period talks. We should give peri talks. And here you go. So, but it is one of these things that's gentle, especially the 30 or something year olds that haven't had kids yet or whatever. And their men's freaking out that my doctor's now talking.
Yes. Well, and it's so good for you and I to just reiterate, even if you're perimenopausal, you can still get pregnant. Absolutely. Right. And so it is funny how it's gotten such a bad rap and so much negativity, when in reality, we should just talk about it as one more life stage that is a very natural, normal process that might make you feel lousy. And so we can help you so you don't feel lousy, but it's better to know.
Majority of the people can go on menopausal hormonal therapy. There's few contraindications. You have to find someone that's willing to talk to you about all of that. Yeah. I'll just plug it again. The Menopause Society, or used to be known as North American Menopause Society, there are a list of clinicians that the majority of practice evidence-based medicine. There's some outliers, of course, but the majority of them do practice the evidence-based medicine and follow the guidelines by the Menopause Society. Yeah. And that's really important to find. So I think, as we're concluding our podcast, tell us a couple of take-home points that the listeners should, jot down. Okay. All
right. I'm going to give you three, and I'm going to try to make them quick.
Okay.
One is, please know what you're being screened for every year at the gynecologist. And again, it's typically your breasts are being screened, your cervix is being screened, you are visually being screened for your vulva. And if you're over 45, your colon should be screened, meaning you should be told to go get a colonoscopy. That is it. You're not getting screened for ovarian cancer or uterine cancer. If you had uterine cancer, it would usually show up with heavy, painful bleeding or just heavy, irregular bleeding, which often is not uterine cancer. But again, you're not screened for it, just so you know. And if you have ovarian cancer, typically the symptoms are subtle, but they're not silent, as many people say. So if you have bloating or pain or pressure, please see your doctor and ask them for some imaging. Again, whether it's an ultrasound or an MRI.
Right.
The second quick thing I always say is be proactive, but not paranoid. We cannot kind of be in this mindset of saying like, oh, I'm going to go to the doctor and ask for this if we're paranoid that every time I have pain, it means I'm dying. You're most of the time not dying.
Yes.
But if you are not proactive about it, you'll miss those times and then be more likely to get to an end stage. And the last thing is I have like my little quote that I made up years ago. Nothing is ever only, everything is always and. And it's a mouthful, but basically it means there are no black and whites. Like I say this all the time. Should you have a C-section or vaginal birth? They're both good for different reasons. Should you breastfeed or formula feed? They're both good for different reasons. Should
Right.
you go on hormones or not? They're both good for different reasons. So, and I would say this, and I think you agree, that now on social media, we are unfortunately seeing big factions in all of those and in many more examples.
Yes.
Everyone should go on hormones or no one should go on hormones. And what I really don't want is this new wave of people saying everyone should go on hormones, because then the people who either can't or choose not to, or for whatever reason, really, really medically are unable to, are scared into thinking that they're going to die of dementia and osteoporosis and all those things. Right. And so again, there are nuances to all this. There are different endpoints. Mm-hmm. Find someone you feel comfortable talking through all of it, and maturely recognize that you are different than your sister or your neighbor. You can learn together, but you might have to make different choices. It's not a black and white answer. It never is.
Right. And I always say, like, for those of us in this space, it's really important, not to practice cookie cutter medicine, right? Menopause medicine, sex medicine, all this is not cutter medicine. Everyone has to take into account people's family history, their social situations, their social determinants of health, all of these things that impact their either ability to take medications or their ability not to be on medications. I mean, there's so much involved. And so I think that's why they termed it precision medicine this last year at the menopause conference. But it's absolutely true. Like, we don't practice cookie cutter medicine. You shouldn't. I mean, what's worked for me won't work for you potentially, and vice versa, right? So take all of that into account. And I think that finding someone to do that is really, really critical. And I would just be wary of some of the stuff on social media when you people that are pushing stuff. I mean, there are probably very good supplements out there, but there's a difference between, I think people poo-poo big pharma a lot, right? Because it's big pharma, they make money. Right. Guess what? So is the natural and supplement industry, and they're not regulated at all.
And they're not spending the supplement industry, as you and I know, who are making a lot of money, are not using that money for studies. At least big pharma, who I would ding in there's a million ways big pharma is messing things up, but at least they're spending money on the studies.
They can't be out there in the world without, we were saying that, at least when it comes to pharmaceutical companies, there are studies that back up, they can't even be out there in the world without having been studied on humans and all of the good stuff. So there should be evidence behind their use. And I'm sure there are good supplements, as we said, but we don't always have good data on it.
Yeah, exactly. Yeah.
So thank you so much, Dr. Ghofrany. Shieva, thank you for being on my podcast. I really appreciate you. I love listening to you, and, hearing you speak about your journeys and your advocacy work is amazing. So thank you once again.
All right, my love. Thank you so much. That was fun.